Correspondence was received for membership. Dr. Krupi recommended Dr. Constantine Carrington for consideration for future REMAC seat. Resume was received. Dr. Harris submitted Dr. Mark Hanna's resume for consideration as an alternate representative for the pediatric emergency medicine seat. Yeah, so that will need a vote. So is there a motion to approve Dr. Mark Hanna as Dr. Harris's alternate for the pediatric emergency medicine seat? Okay, is there a second? Okay, any discussion? All right, all those in favor? Any opposed? Any abstentions? Okay, motion carries. Okay, resume was also submitted for Bob Oakley, position to be considered for any future opening on the REMAC committee. Dr. Langsam nominated Joe Spencer to remain the REMAC committee chair. A resume was received. Dr. Coleman nominated himself to remain the second vice chair. A resume was received. I nominated myself to remain first vice chair. A resume was received. No other nominations at this point have been received. FDNY Search and Rescue Field Medicine Symposium will take place April 24th to 27th of 2025. You can register at the website, which we'll leave out. I believe you have some flyers. There's flyers on the table. If you could grab one during a break or on your way out, I'm sure they would appreciate any encouragement of attendance at the conference. New York State Bureau of EMS and Trauma Systems, there's no notices, enforcement actions. Ariana Mortensen, Albany, New York, 449785, is revoked effective 1/17/25 for violations of NYC RR 815A, 815A, 800.3, and 800.3A and L. Revocation is stayed pending successful completion of a paramedic refresher within 24 months, 3-year probationary period, $2,000 civil penalty. The civil penalty is stayed. Empress Ambulance Service was assessed a civil penalty of $20,000 for violations of 10 NYC RR 821 A, B, and N, 800.22, 800.23, 800.24. Lindale J. Brunson, Elmont, New York, 165731, subject to completion of a 3-year probation effective 1/6/2025 for violations of 10 NYC CFR 803, 815, and also set the civil penalty of $2,000. Stephen Stinson, Niagara Falls, New York, 433772, suspended for 1 year for violation of Part 816, 1 and 2, suspension of state pending successful completion of 3 years probation, civil penalty of $4,000, of that $2,000 state pending successful completion of probation. Carol Otar, Woodhaven, New York, 468572, suspended for 1 year, effective 11/26/24, violations of 816A, 1, 2, 3, 9, and 11, assessed a civil penalty of $12,000. Of that, $10,000 shall be stayed pending no further violations during the probation period. Katisha Garcia, Brooklyn, New York, 482007, suspended for 1 year, effective 11/26/24, violation of 816A, 1, 2, 3, 9, and 11. Suspension is stayed pending successful completion of 3-year probation. Civil penalty of $12,000. Of that, $8,000 stayed pending no further violations during probation. Christopher Pelock, Farmingdale, New York, 167410, suspended for 1 year, effective 11/22/24. Violations of 816A1. Suspension is stayed pending successful completion of 1-year probation. John Kevar, Worcester, New York, 220841, revoked effective 12/9/24 for violation of 815A2, 815B1, assessed a civil penalty of $2,000. Corona Community Ambulance Corps, Corona, New York, 7344, revoked effective 12/2/24 for Article 3012 1F violations. Enforcement actions for both providers and agencies can be viewed on the New York State Disciplinary Action Enrollment page. New York City DOH, nothing from ambulance agencies. CME and training, the following events were received and distributed. Northwell Lenox Hill Hospital hosted a Comprehensive Management of Stroke 2024 conference on November 14, 24. Mount Sinai Division of EMS and Disaster Preparedness Grand Rounds hosted a challenge and opportunity in pediatric cardiac arrest in October 24. New York City Health and Hospitals hosted a fireside chat outbreak preparedness and response with Dr. Laura Ayapakoli, Dr. Sira Madad, and Dr. Nikki Romanik on October 23rd, 2024. The office sent the following correspondence: agenda minutes and associated attachments for the meeting. The brief New York City REMSCO newsletter was distributed to the region. Following members have been issued removal letters by the REMAC committee due to their failure to maintain the required attendance in accordance with the bylaws. Robert Winchell, Matthew Fink, Wallace Carter, Eric Cohen, Anne-Marie Denti, Louis Marshall, Dominic Battinelli, Efren Brendan, Sean Graves, Anthony Shalish, and Yadija Langson. Following members have been issued warning letters by the REMAC due to failure to maintain the required attendance in accordance with the bylaws: Michael Thatch, Robert Krupe, and Eric Kluge. That is the end of the correspondence. Next, executive committee report. Yeah, the executive committee has not met since the last meeting, so nothing to report there. And we can move on to subcommittee reports. Dr. Barlow. Can you hear me? Not on. Now it's on.
Joe? Thumbs up? Excellent. I want to be honest with you. Credentialing met on January 16th, 2025. Again, is open meeting. Updates from the meeting is the exam that is ongoing for the original certification, and data collection is progressing on an ongoing basis, but once we have a greater number of test takers from a variety of programs, the test question outcomes will be demonstrated in statistical format here. Currently, the test is a little bit too many of one program in particular. We don't want to be highlighting one education group only. We are pending the training and education update on stroke for the region, as will be a recommended annual update, which is born out of anecdotal experience as well as quality data regarding needs for increased awareness of the existing stroke protocol. So in addition to the protocol updates being part of the yearly credentialing cycle, this training initiative on stroke protocol in our region will also be an expectation for maintenance of certification for paramedics in the region and physicians in the region. There will be some manual updates coming regarding expired providers, people who have essentially let their credentialing lapse, as a means of allowing them to maintain, outside of an extension. If anybody is interested in helping craft that language for the manual, contact Kevin Ward or myself. We're going to be working on that in the next month's meeting. It basically allows us to reduce loopholes and also reduce people from a lapse certification required to take like a new original course. So it's a means of helping providers stay on the street if they lapse for one reason or another, whether it's service issues, medical issues, etc. But the way the manual is written, it essentially will make them be incapable of working because of non-professional reasons. The medical control physician component is ongoing, and we had some small group meetings. We do have some documents to present today. Do you guys have those?
Have those, do you want to do it now, or you want to come back to an unfinished business? That's up to you. Is it, do you have it, can you project it now? Or?
That's the Section 2 document, the REMAC OMC physician. Michelle, you have that?
It was sent out, but I don't
Okay, it was sent out. Okay.
Yeah, it's over there if you want to project it. If not, I think it will pass a copy.
So it was sent out in your email. I'm going to humbly decline projecting my laptop on the screen. Just for a report to this group, the ALS requirements for care document, which is one of the key components of our group's written legislation discusses the credentialing of a REMAC OMC physician. This existing document was a bit antiquated and also demonstrated some impracticality for those to seek credentialing. So we've conducted some small group meetings in the last 6 weeks, 8 weeks, with input from multiple members of the regional leadership. A document was created and revised and distributed. I would submit that this document be voted on for passage and to allow our ALS requirements for care to be modified to demonstrate these changes.
Can we, I think it's probably easier if we split it into the two that they are, right? Let's take section 2 first, the online medical control physician.
So I'm specifically not discussing the agency medical director one right now.
Yeah,
So
I just want to make it clear.
Yeah, so this is
Right?
just
Online medical control
REMAC
physician,
medical control physicians.
not the online, not the agency medical director, so section 2. Ben,
I don't think agency medical director is ready for this meeting.
okay.
Can you display it?
Can you display it?
Might be beneficial to.
No, it may be beneficial to display
Does
it.
that have a map?
Or if someone can display it, who's over there, or if they have it.
So I'll just go on my computer.
If you have it, yeah, that would be great. And then, yep, and then we'll, so,
Dr. Lai, do you need me to send it to you?
No, we have it.
I have
okay,
it.
great.
That
So
would
what
be
we're
tremendous.
discussing is this, just for everyone's clarity. Online medical control physician only, has nothing to do with agency medical director, and we'll open it up for discussion now. Dr. Zabro.
2 points. One is, I guess I'd make a motion just for clarification. Pam, can you go down to number 5? Part B. Correct me if I'm wrong, this part B, number 2, I believe what it says, proof of one of the following 2 choices. I assume it's sort of saying either you do the external resuscitation classes, both of them, both the ACLS, BLS, PALS, and trauma, or you do proof of practice, right? That's the intent.
That's a grammatic, like it should be like a 2AB and then a, or a 1 and then a 2.
You either need.
It needs to be headings under there, yes.
I think you're doing one of these 2 choices, either
Correct.
all of external resuscitation classes or proof of practice.
What you just said is the intent of the document.
The other thing is about the proof of practice, because I know it looked like there was
Sorry,
language.
did you make a motion
Well, my motion would be to wordsmith it.
You were asking for clarification.
or a motion?
Yeah,
Are you making a motion to do what? Number them or something, or? I mean, I think what you're bringing up is a grammatical issue, right?
yes, I mean, it would be proof of one of the following 2 choice, either A or B.
yes.
And external resuscitation classes is A, and proof of
Correct.
practice is
I don't think there's any does anyone have an issue with that? All right, we will do that. Yes, for
All right.
clarity, we'll do that.
And then my second thing is just for
Wait, Ben. It's either the resuscitation classes
Both, which is A,
or proof of practice.
which is B. Correct.
But the resuscitation classes include the ACLS, BLS, PALS, and the trauma requirements.
Right. I just think right now, the way it's written, someone could misread it as thinking
Right.
what the 2 choices were.
He's clarifying it, right? By adding like a 2A and a 2B, so it's either A or B.
So I'll change the bullet.
Yes, to an A and B.
And my other thing is for just discussion, for proof of practice, because it looked like there had been language about the amount of practice, because I think we're saying someone who's continually practicing online medical control and is currently board certified doesn't need any of these classes, and the way it's written right now, it looks like what constitutes practice is up to the medical control facility. So this is basically saying, unless I'm misreading it, that someone who does 1 shift a year, does 1 shift every 2 years, as long as that medical control facility is willing to send in a proof of practice for them, they get recertified.
Yes, good question.
That is
Paul,
true.
do you want to comment on that?
So the group decided that that's going to be the definition. It leads to a little more laissez-faire operations, but it's not in this group's capacity to restrict what an agency defines as a need. If an agency defines that this person is a need, and they've proved practice for that agency, that's where the boundary is, Ben.
So you're right, Ben. in previous meetings, there was discussions of years of different, right? And then where the group settled on is, we're gonna trust the online medical control facilities director to make that decision. Now, we can change that, but that's what this document currently
I'm
says.
not against it, it just gives me pause that you have a medic out there who's calling for orders, and the person they're talking to who's board certified in something that's not emergency medicine, it's not EMS, and they have none of these certifications because they do some level of medical control. It gives me pause.
Is there a way to project that a little more clearly?
I don't know.
Okay.
Do you like make it bigger, you mean? Or
No, it's very blurry.
Oh, big.
Yeah, I mean, also I'm developing cataracts again.
Because of the tracked changes. So this situation is referring to someone who's not board certified in emergency medicine or EMS medicine in their pathway to recertification. That they have to complete the resuscitation classes on the outside as well as, or have a proof of practice, I'm sorry. But most of us are not gonna fit into this. This is a little bit of the weeds to maintain people who have been doing this. And that way we don't have someone being left behind.
Okay.
And that's the other point of this, it's not for initial, it's in other words, they've been doing this.
So,
Ready.
Dr. Lai, can you scroll up a little bit or make it smaller? Where A is the recertification, 5A is candidates board certified in EM or EMS medicine. They just complete the updates. So these are for people who are in this medical control role, aren't board in emergency medicine, aren't board in emergency medicine in EMS. How do they recertify? They do the annual updates and they have to maintain their resuscitation classes, which is essentially a legacy from our existing process, but it wasn't clarified in the former document and it led to some loopholes.
The thought is that they're recertifying, so they're currently doing this, and if their current online medical control agency is satisfied with their practice and the amount of their practice, then it would be up to them to say, yes, they meet the practice pathway. Other comments?
Okay. There's a lot in this document. I hope it was read. So this is a formal submission from credentialing committee and the small group tag regarding medical control credentialing. Again, we're holding agency medical director until this is completed.
So is there any other discussion on this document for online medical control physicians? Use the mic, but go ahead. Oh, okay.
I think you have concerns about also something in the beginning of the document regarding the 2 years of residency or something like that. Was it in this document? Oh, was that it?
Yeah, that's in the initial certification up top.
Yeah. Oh, yes. So I think we had a question.
That's number 3.
We had a question, 3A sub 2. Board eligible, as the definition that ABEC uses, requires, I believe, completion of residency. And this has completed 2 full years of residency. So there was some.
Right, but you could be eligible outside of EM, right? So ABEP does. But if you're, let's say it's family practice, but like another board could consider you board eligible.
After 2 years?
Possible. I believe that was the discussion on this.
This is a lot of documentation of existing pathways and loopholes. Ideally, people are already board certified in emergency medicine or EMS. But there was the concern of the senior resident being able to do it. And the issue was senior resident in a 3-year program versus senior resident in a 4-year program. So essentially, we wanted to make it as if it was, if you were PGY4, PGY3 in a 4-year program, you wouldn't be able to do this the way we had it written the last time.
Right.
Because you had to be in your senior year residency.
But Brad's technically correct. In emergency medicine, you are not board eligible after 2 years of residency.
I don't think in any specialty.
Right. You usually have to complete the residency to be board eligible.
Is there anyone in this area who's not using residency medical control directly being supervised by someone who has a certification? But is anyone using residents who have gotten, or getting their residents this certification? Like, do we have anyone who's getting the certification under the 2 years of residency, but they haven't completed residency?
So to answer your question, Dr. Zabar, that was brought up in the small group as well, that this seems very clunky. Might not be needed for a lot of people. I agree with you. I don't know if this is even a pathway we have to show here.
Because I know in the history, this was before my time understanding, is that I think we, the fire department, at one point was using or looking at using residents, but for city rules, we can't. So I don't know if this is just historical or is there a reason to keep it?
Dario.
I was around a little while ago. The, have to press this now?
Yes.
Yeah, that was purely historical, and that had to do when 9/11 existed, and it had to do with the lack of physicians for telemetry coverage in Maspeth, because we're essentially the only game in town. And so senior residents in emergency medicine, but then the rotation were permitted to apply. That was, and then the city said, no, you can't use them because of the licensing issue. So that was discontinued, so this
So you think
section
it's
should
just a
just be
holdover?
removed. It doesn't apply to anything we would do today or in the future.
What we tried to do is to not cut out that process and maintain it as a legacy, even if not a lot of residents are going through it. But the concept of a provisional pending their board certificate, what if somebody gets their board in February instead of September? They're not allowed to do it for a full year. So we said you would be a provisional OMC physician, and you'd have to recertify with your board because by that time you'd have passed your boards.
Well, unless I'm interpreting it wrong, I think all people are saying is strike that first bullet, not remove the board eligible section.
Or change it to have completed a residency.
Well, actually,
Because if you've completed a residency and you're waiting to take your boards, you're,
so if you read 3A, this is for candidates that are board certified or board eligible in EM or EMS. So that's inherent that you've completed
Correct.
the residency.
Yeah, that's what I'm saying. If you strike that first bullet, the 2-year thing, then everything else still applies, right? Like you could ask him for a letter from the program director, right? Completion.
Am I allowed to make an ad hoc change?
You can,
We can take a motion.
we can take a motion. You do whatever you, right.
make a motion to strike the first bullet too.
Second. Second.
Okay, discussion on the motion to strike. The first. Yes, sir.
Yeah, so as Dario said, historically it was there that senior residents could apply, right? So a third-year resident in a 3-year program is a senior resident. So we couldn't get people to come in. We finally got a resident a couple of years ago, went through the whole hiring process for us, and the city said no. So it didn't work for us. But are there any, like Ben said, are there any facilities that do have senior residents that are able to get their work as a REMAC physician? I mean, if not, then that doesn't apply anymore. I know there's a discussion on the motion, but the other thing too is separately, the REMAC light credentials. Should that be in the document somewhere, right? Those people that are for the, what is it called? The community health.
Telemedicine,
Right. I mean, that needs to be addressed. I mean, I'm sorry it's out of turn.
So this is not handling the telemedicine at all. We're steering clear of that credentialing process for the time being, and using this as a pilot to identify what's actionable. I'm happy to strike the 2 years of residency. I'd rather make this document leaner and more standard as opposed to more one-offs. So if the city is having trouble with senior residents, just as an anecdote from Northwell, we would have residents answer the phone, but they always answered it in conjunction with a physician who was medical control trained. So it was always a two-phone concept. So it was always supervised. So whether the resident was medical control certified or not was irrelevant because the person handling the call was truly the physician that was overseeing it. So I think this is gratuitous as part of the group that wrote this. So I'm happy to strike it.
And as far as we know, there are no emergency medicine residency programs that have their senior residents become on-line medical control physicians. I'm just curious. Probably not.
Answer the phone or become medical control
I
physicians.
don't believe so.
Okay.
Yeah. All right, any other discussion on striking that bullet? All in favor of striking that first bullet? Raise your hand. I think the final protocol.
It's just a vote on the
It's just a
motion.
vote.
There's a motion on the amendment.
Yep. Okay. And
So,
Okay, hold your hand up if you're approving again. So you can- Oh, I don't, yeah, well, 16 people haven't voted in the affirmative, so it's all passed. Okay, did you get everyone over here? All right, one more time, raise your hand if you're
Trying to
approving.
get all positions. 1, 2, 3, 4.
Yeah, no, okay. Anyone opposed? Abstain, so a couple abstain, yeah, two or three. All right, so that first bullet is stricken. Back to discussion of the overall document.
Can we make a motion to hold all future votes on Zoom?
You could make that motion, it would be probably out of order because it's probably not allowed by the open meetings law, but,
Please don't distract my document.
Paul, back to you, overall document, any other comments or discussion?
If you need a high level, it basically talks about initial certification, the pathway, recertification, the pathway, and then the final piece is maintenance of REMAC OLMC faculty, and how the small group faculty who train the courses, the instructors of the content, will maintain their instructor status. Thanks to everyone who participated in building this and all the input at these meetings and others that created this document.
Any other discussion or comment? Yes, sir.
Yeah, I just, people who are actively practicing online medical control, I don't see any value added in making them do all the courses, all the, badge courses. So even if their initial certification lapsed, I think that people who are actively providing medical control should not have to take any of those courses. And I think that under the lapse certification, we should change it as well to or either one.
Is that a motion?
That's a motion.
I second it.
There's a motion and seconded, discussion on the motion. His motion was to remove, people call them merit badge
For
classes. Huh?
lapsed certification, to remove the requirement to have
Right,
both.
so
and make it
under the
have either one.
recertification process,
5C2.
5C2. You put it on the screen.
So, Nathan, I'll just provide, from the group's feeling that was the one more step beyond a non-board certified person. It was a matter of stepwise progression, and I respect your feelings on the matter, obviously, but then there's no way to tell the difference between a non-EMEMS board certified person who's just renewing versus someone who let it lapse.
I understand that, but I think we're just kind of punishing someone with courses that don't add anything to the medical care in the regions. That's why I made the motion to change it back.
Do you have a suggestion besides making it equal to a non-board certified person? Is there another proxy for education that you could show that this person maintained a standard when they let their credentialing lapse?
I mean, if they're actively performing online medical control, I don't think we need that.
As defined by whom? Performing medical control.
Same as the person with internal medicine credentials.
It was brought up in the room that was a problem.
I mean, that's what we're going with. I don't.
All right, so, yeah, let's done.
But if someone is not risk medicine trained in another field, besides what comes, how are they going to be, and I understand REMAC puts out training material, but how are they going to be up to date on standards that are out there? While the course is not perfect, they do have standardized information, so why should we ever have, why should that people be teaching ATLS? Maybe he's wasting his time when he teaches it. Why do we have any of these classes certification? It does provide some standards information to people up to date on what's out there, what's best practice.
That was the discussion of the group, that they felt that however good or bad those courses are, they would at least make sure they were up on current guidelines and recommendations.
Yeah, I think it's pretty clear what the issue is here, and in the group we had this discussion, and most people felt that way. But
No,
I feel
yeah.
differently, so I
Of
want to
course,
bring it up
no,
to
that's
the
fine,
REMAC for a
yeah,
vote.
totally fine.
Just want
Mike?
to express an opinion.
So I would just bring up that, right, if I am going to sign up or get services from an OLMC, my medics are going to call an online medical control center, and I'm relying on that service. I would want to know that there is, right, if there, if we're creating a very laissez-faire system where we don't have to have, kind of the definition of what ongoing medical control is, then I think we need some standard to have, to hang our hats on. And I would say that I do think it's important to keep up to date with some element of kind of emergency and resuscitative care. So I would be in support of I would be against changing the current language.
Okay. Other comments? Yes, sir. Can you just come up to a microphone so that, and turn it on so that,
Isn't it the case that emergency medicine physicians in New York have to maintain a PALS card?
Yes.
to practice, to see pediatric patients in an emergency department?
Yes. So I think that we should, because if you're not EM, then that wouldn't apply to you. I think they should meet the same standard with having a current PALS card, which is the same as physicians seeing
So,
pediatric.
yes, so Brad is correct, it's true, it is PALS or equivalent. So like a health system, and one of them may have done this, can create their own content that meets that same, in the health department's eyes, that same level, and they can do that instead. Brad and then Paul.
So I would just bring up in support of Nathan's motion that if we were to trust the agency OLMC facility medical director that's doing the attestation that this provider is capable and up to date, then, that's the second part of the requirement. Then we wouldn't need them to take, these medical courses.
Paul and then Ben.
So I'd like to just bring up that Dr. Reisman is suggesting that people without board certification simply need an approval from their agency medical director to continue giving medical decision-making in the region.
Continue, that means
For
they already
recertification,
made
correct?
the
Recertification, yes.
right?
That the standard is being diluted, and there's essentially no impetus to maintain your board certification to continue giving physician advice to paramedics in the region. And I think that's a dangerous slope for all of us to take as a region. And I'm not on the side of saying that the ACLS courses are the end-all be-all. I think removing that component should be in place of something else. If you want to remove that, replace it, as opposed to striking it. And I think the ACLS classes are there for practicality. That if you decide to let your board certification lapse, the thing that defines you as an expert in your career, to simply need a letter from your boss is a tremendous slope that we may not want to go on. And I would suggest another education course, maybe something internal to our region, put on the learning management system in place of that. But I think the issue with board certification is we weren't aware that people without a board were actively practicing medicine, and that needed to be clarified. This is a method of clarification. It might not be perfect, but it's a method. And before we strike it, we should seek to replace it.
Thanks, Paul. I believe there was some discussion on internal content, and the concern there was maintaining the currency of that on the LMS, and it would be a lot of work, but Ben.
Yeah, and I agree with Paul, and I think it's great that everyone has to do the online LMS training, but the truth is our protocols are really based around giving guidance to CFR, EMTs, and medics. And a lot of what medical control is doing, as you know, is these cases that are not exactly covered by the protocol, and being updated in protocol changes doesn't really tell you when should you treat rapid AFib, should you allow them to sedate this person for intubation. And I think the way it's written now, we say, here are the checks. It's, for recertification, there's, you do the LMS and you have that board certification and you're constantly practicing, or you do these courses. So there's these like 3 different things. And I personally don't feel comfortable that someone who, they let their boards lapse 20 years ago and they're not doing any courses, any education. The only thing they're doing is the online LMS, that, the fact that they're do a medical control shift now and again is enough. So I think right now we have almost these 3 levels. And so if we just say, well, it's enough that you're constantly practicing, then the board certification doesn't matter whether it's EM or non-EM. most of this document no longer really means anything. So I think we should leave it the way it is.
Let's point out that none of the courses that are listed teach you any of those things. Exactly.
I mean, at least there's discussion on, this is the, when the way CPR changes, when, the treatment of arrhythmias, which is covered in ACLS, and hopefully some of that stuff is also covered in their recertifying their boards. But are those courses great? No, but at least we can say, hey, there's some education that this person has done in addition to the online LMS, and we're saying, or they're doing their board certification. There's, and the fact that we don't get a lot out of it as emergency EMS people. Someone who has their boards have lapsed for 10 years, I'm hoping they're gonna get something out of those courses. Because otherwise they have no other education.
Okay, yes, go ahead.
Is there any way, I know there's a motion, but to amend that to say then, not just the agency saying that, you work for telemetry, maybe for that level have a certain number of hours or something? That would be one step above,
So, yeah.
right? Because right now in the initial,
Motion to amend.
Yeah, you can it's a second order amendment. You could-
well, I mean,
Yeah.
yeah, but I want to see if this passes or fails
Okay,
first.
so we'll vote on this motion, then we'll come back to that. Okay. Any other new discussion on this motion? So just to clarify your motion is to strike, right, 5C2 by removing the quote, merit badge courses for lapsed certification. Is that correct?
No, it's to change it to the same as the one previous, that it's either the merit badges or active practice.
Okay.
Which sort of says, why do we have this distinction between your
So
current or
just
your
clarify, so you're not striking 5C2.
Well, basically, I can't really see that,
Scroll
well, but
down
I
a
think
little bit
we could even make the thing before it or be either,
So 5C2A, you're getting rid of, and you're just going with proof of practice. Is that
no,
correct?
I
no.
want to change and to or.
I want to make 5 the same as 4. So we could even get rid of the whole 5 and just make 4 be like people are certified in these XYZ specialties or have lab certification.
Okay.
That would mean basically everybody that's not EM or EMS board certified follows the second half.
No, or work, but have to be at one time.
Yeah, Paul.
The work on this document was meant to be done in small groups.
And it was, extensively. But we have a motion on the floor. So the motion is to make 5 read the same as 4, essentially. Is
Correct.
that correct?
Yeah.
Okay. This will be a roll call vote. No, this is an amendment. So all in favor of changing 5 to the same as 4, raise your hand. Just keep them up for a minute. Yes. Okay, if you are opposed to this, raise your hand. John, are you? Yeah.
Please.
Okay. Oh, you can't, only one of you count. Yeah, okay, so. Abstentions? Any abstentions? Okay. Motion fails 10-8. Other discussion? Do you want to?
Yeah, I'd like to, so for the 5, whatever it was.
The
For
lapse.
that, right, for the lapse, to add in the section of, so get rid of the merit badges and require a certain number of hours for that person to have worked clinically, I mean, in telemetry, and not just as it was in.
So in this case, what you're saying is everything above the end you would get rid of, and in proof of practice, you would put something in there about a minimum number of hours of practice?
Yes.
Is that what you're saying? Okay. Paul?
This was discussed in a small group and felt to be difficult to practically track or to essentially to police, as Dr. Raybridge puts it. So the content of hours was not chosen as a mark because it was unobtainable or unreliable to measure.
Doug?
Just
Just turn your mic on.
Just to add what Paul said, it was really puts the burden on agency medical director or online control physician to verify their practicing and so on. It was really hard to qualify. We talked
Which is
about
why
at
we
least
felt
one shift a month.
the
like, what
signature
it?
was,
Yeah. So
we
it
trusted
lessens
the
that
medical
burden, it just puts it on the online control physician to verify.
Glenn?
Yeah, it's not a burden. Look, the fire department, medical control is the largest, right? I know exactly how many physicians are working how many hours, how many shifts, right? And there are quite a few in this room that are online medical control physicians for me that are not even meeting our requirement of 8 shifts per year, right? And I threaten them with, we need you to turn in your ID because we don't need you anymore. And then all of a sudden they'll try to catch up. So it's not a burden for us. I can't imagine for the smaller systems it's a burden. So I don't agree with that. I can tell you exactly within the next couple hours, if we needed to, how many shifts each physician at my telemetry has done. So it's not a burden.
So Glenn, is your suggestion like 1 shift a month? Like what would your?
Hold on. Yeah, well, yeah, so we're just discussing, right, at the moment, we're just discussing the concept. You have not thrown out a number that I've heard. It's just
Correct.
the concept of hours.
Is there a second?
I believe there was a second.
Second.
Yes, yes.
This was second.
So, yes, so,
Operate.
I just want to clarify.
go ahead.
We burns out where we work, but like if, for say you know, as an inspector, if someone is not practicing, then you don't have to sign off on it. So it should be
Exactly.
like yeah, that's my, I'm just saying, it just doesn't put the hours on there. You could determine, hey, you know, this person's not doing enough shifts to meet our standards. Each shift, so I'm not signing off on it. And then they lose your certifications.
I understand, but you're saying that it's impossible to figure.
Mine too.
Maybe impossible is not the word.
Yeah.
You said it was difficult and a burden. I'm telling you, it's not.
And
I
it's
can tell you, give me a name, my telemetry physician, I can have within the next hour, how many they did for 2024. I can tell you that.
I didn't
It's not a
mean for
burden.
us, I meant like for any telemetry unit where, how we know if the doctors in the ER are covering telemetry or the clinical, it wasn't really meant for our.
Okay, I'm sorry.
So this is meant to be an academic standard, not necessarily an operational metric. And with all due respect regarding hours that people are or aren't working, how do we know even if you're taking call that you're getting any calls? How many people take calls for volunteer agencies that they did an 8-hour shift, they got no calls? So this is meant to be that you're demonstrating an academic standard. That's what puts our board in ABEM. And I'm happy to build this now and evolve it as we see fit. But this lapse certification piece that is a sticking point is essentially put in place because we weren't watching what was happening on both sides, on the REMAC side, on the physician side, and on the employer side. If this works, no one should be going through the lapse certification piece. Like this is like essentially an appendix for an anecdote. So ideally, we're not looking to make anybody have a hardship in maintaining their certification, but there has to be a benefit for those who maintain their board and a difference for those who chose not to.
Okay, Art was next, and then Glenn.
Yeah. Forgive me if my knowledge of the online medical control practice outside of MassBeth is limited, but it strikes me that if there are facilities that are providing, online medical control through individual emergency medicine physicians who are on shift and have other responsibilities. Let's say they get 1 or 2 calls during an 8 or 12-hour shift. How do you actually quantify that in terms of, how many hours were put in? I think it's clear from Glenn's point of view, that I know he can track it, but I'm concerned about other facilities that may utilize the emergency medicine physicians who are on clinical shift, and taking care of patients in the emergency department, and how measuring their hours is actually going to work.
That's Glenn.
Yeah, so I can see that part, Art, that you bring up, but again, Paul, we're talking about the online medical control physician, right? You're talking about volunteers. I guess there are some facilities that have volunteer online medical control physicians. I'm not aware of that, but okay. Now, I know you haven't been a telemetry physician for us in a while, but tell me one shift you had where you had no calls. Come on, that doesn't happen. Was there a shift that you worked that you had no calls like you just said? No. We're talking about telemetry, right? Online medical control. You're talking about volunteering, I don't know what.
No, actually, no, we're actually not talking about telemetry. We're talking about the New York City REMAC medical control physician credentialing. It is not about the fire department. It's about the
I never said
REMAC.
about the fire department, I'm talking about online medical
Yes.
control. Our facility, right? When you were there, did you ever have a shift where you got no calls in 8 hours? I am sure you did not.
Okay, I think, all right, Paul. I think the point he's trying to make is that it's a regional document, obviously. I agree that it'd be almost impossible to have a shift at your facility and not have a call.
Impossible.
But it's, regional policy. Eric, did you have a comment?
Yeah, I just wanted to echo Paul's point. Very agrees.
Come to a microphone.
I'm just gonna say, I agree with Paul's point that I think there are variable degrees of quality with the number of hours. It's hard to qualitative assess your standard, but having actual coursework makes it more standardized and fair. I also feel like if your certification lapses, you should have a little bit of a higher hurdle to overcome because it may be indicative of a standard that the individual has where they may have lapsed on other certifications with a professional practice. So agree with some of the points that we made here.
All right. I think we've had sufficient discussion. I think we can move to vote unless someone objects to that. Yes, and I will confirm the motion. And correct me if I'm wrong, but the motion is for lab certification, right, which is 6, I believe? 5?
5C.
5C, so lab certification above the end.
Recertification pathway.
Yep, the recertification pathway, to strike the merit badge courses and add in proof of practice a minimum hours or shifts, did you say, when you made the motion? Yeah, I don't think you specified, but
I did
have a minimum amount of ongoing experience.
Clarification.
Yes, sir.
Didn't we already agree that we were not going to strike the merit badge?
We agreed for that for the recertification for people who are not EM boarded. This is for people whose board certification has lapsed.
Dr. Kubin, this is for providers who've let their board
Any
certification
board
lapse.
certification. So they're, yep, so this is for non-board certified physicians who have lapsed, that they to strike the merit badge courses and add to proof of practice a minimum amount of recency experience.
I think we need to actually have what that is to vote on it. I mean, I don't know, depending on how many hours it is or how many
We either
shifts.
do, or if it gets approved, then the next step is we'd have to discuss what that minimum is.
So the motion is to insert a blank and
Unless-
vote on a blank.
Again, we're not good with then just having the agency or the online control physician, medical director sign off, so.
Well, I don't think that was Glenn's, his motion wasn't to make it identical to,
Not to make it identical,
Right.
but to say that for those who have lapsed, it's not just the medical director of the facility saying, oh, he did 1 this past year, I'm good. They have to have a certain minimal time because that's the added,
that's the
Burden.
difference now, this would be the difference between the
Five,
first
4
5
and
and
5.
4 and 5, right? Would be, for 5, for lapse, you'd have to have some minimal experience. Just try and turn your mic on. Go ahead, no, you can talk, but turn your mic on.
Doesn't work, I'm still waiting.
You can take mine.
No, it's okay. I don't know what the initial discussion is, and Paul can, he's got a better memory than me, what we did initially discuss those clinical hours were. I forgot, that was the initial talk.
A main point of this document was to achieve practicality and longevity. And I think with the evolution of the learning management system, we can identify things to maintain credentialing for people who lapse their board certification, but in the absence of any other educational standard, this is the price of the person not going to have to go back and get their board to maintain their status. Is 3 very obtainable classes.
And a number of different hours and years and shifts were thrown out in that discussion. I don't know that any was ever settled on. But again, the motion is to replace the merit badges with proof of practice and some minimal recency of experience requirement.
So if that passes, are we then going to vote on the
If that
number of
passes,
hours?
then obviously we can either decide what that minimum is, or we can send it back to the committee to decide. But that's the motion. All All in favor of replacing merit badge courses with proof of practice with a minimum recency requirement for people whose board certification has lapsed? Raise your hand. Okay. Opposed to that? She got it, right? 12? Yeah. Okay. Motion fails. Oh, sorry, abstentions. So back again, the original motion that spent the multiple meetings putting together. Any other discussion on the document as a whole? Glenn?
I'm sorry, I'd like to make another motion to, all right, keep the ACLS, PALS, and BCLS, but get rid of the ATLS part, because I don't think there's any benefit in all regards for a recertification.
Okay. So to clarify, your motion is to strike that second bullet under merit badges that says completion of recognized trauma resuscitation courses, correct?
Yes.
So would that be for both?
Is there
Would
a
that be
s-
for both people who have lapsed and those who have not lapsed? Because it doesn't make sense to strike it
Yes,
for
are
those
you
who have
saying
lapsed.
4 and 5 is the
Both,
question?
correct.
So for both 4 and 5, his motion is to strike the second bullet regarding trauma courses.
Yes.
Is there a second on that motion? Okay. Is there discussion on that motion? Anything else you want to, I think you said it, Glenn, but anything else you want to add to discuss? Okay. Dr. Cooper?
I'll just say that HLS standards do change every 4 to 5 years, perhaps a little bit less often than Art Association standards, but they do change. And, to me, maintaining currency, if you're going to have, the resuscitation courses as part of the requirements, maintaining the currency in terms of trauma resuscitation should be part of the armamentarium as well. Thank you.
Paul?
It was not the opinion of the small group to remove the trauma resuscitation courses when we went line by line through the original document.
Other discussion? Ben?
I'll just say that I think I don't have the statistics, but very, very few medical control calls are about trauma. They tend to be about ACLS, PALS type, arrhythmias, because most traumas BLS or maybe a needle decompression. So I think there's lots of ATLS changes that apply to the protocols, but I don't think it really applies a whole lot to medical control.
Thank you. Dr. Eisen?
Among the fence.
Someone give him a microphone.
I don't know if this works.
Dr. Bailey, can you give me your microphone? With pleasure. Yeah, it's going to turn on. All right, go ahead, sir.
Fantastic. I agree with Dr. Cooper said about keeping up with trauma. We don't get a lot of trauma telemetry, but there should be some type of standard. So whether, I think Paul suggested, we had some type of LMS module, we have to have some type of access. There's a cost prohibition. We've been trying to get courses, and it's very expensive. Whether we do an LMS module in trauma, I think it's much easier than other things, but we should have some kind of substitute.
May I have your attention? May I have your attention? We are conducting testing in the fire alarm system. Please disregard any alarms that you might see or hear. May I have your attention? May I have your attention? We are conducting testing in the fire alarm system. Please disregard any alarms that you might see or hear. This is just a test. Thank you.
So, one second.
Point of order.
Yes.
Just finish.
If it's really a fire issue.
Then we'll leave.
That's a privileged motion.
So, okay, it's getting later. Right?
Yeah, you got it.
So whether we have an MS module, which I think it is much easier to put together through REMAC, or if REMSCO could help sponsor like a PHLS course, because this is a big cost and a barrier to folks. It's a lot of money. If that could be an option to REMSCO sponsor a PHLS class, that'd be open access.
Yep, so just so people are aware, the LMS option was discussed by the group, and I think
for trauma, I think.
yeah, the questions there were obviously it's an effort for somebody to create and maintain currency and things like that. Go ahead.
Just to answer, my focus, and it's not just my document, my focus is we shouldn't be doing anything externally. We have the experts sitting around the room, but we have to have the standards put on the learning management system to say that we've met a certain standard. You can't just have a standard by self-attestation. So what is that work, Doug? So like, ideally, yes, the medical control on trauma, we all know is not that much, yet we have the credentials required there. So either we remove them, but in place of, I would favor replacing as opposed to removing.
Well, I think that's what I was
So
suggesting.
are you suggesting an amendment that instead of removing it, we replace it with periodic regional updates on trauma as
Fantastic,
appropriate?
yes.
Now we got this, is there a second?
Well, that was I can't make a motion, I'm the chair of this.
So you're making a motion
Motion
to amend the
To
motion.
amend Glenn's motion.
To amend Glenn's motion to
Replace the
with
trauma
another
courses with
option
regional
in-
trauma trainings.
That Ben's making the motion.
No, no.
To replace the current trauma requirement with a regional training module. Trauma update.
Second,
I'll second.
Dario
Discussion.
seconded, okay. So discussion on this piece now, which is, again, replacing the trauma requirement, the courses, with a regional update. Dr. Cooper.
As many of you know, my hospital provides the great majority of HLS courses in the region. We run a course a month and 2 courses per month in the summer. Together with that, we run the research course. The research course is an hour, about 2 or 3 hours. It includes the written test, it includes the initial assessment. But prior to that, there's also a 1-hour refresher lecture, which covers the key points. I personally believe that, the content of that lecture, which focuses on the changes from the previous edition, could be converted into a very simple, straightforward LMS type program that I think would do the job that people are asking to be done.
Thank you.
that's fantastic.
Other comments on this motion? Yes, Dario.
I don't want to just repeat everything, but I agree with both people. I think that telemetry does not practice trauma, period.
Yep.
Trauma is a rapid movement, BLS call, and not an ALS call. And we all know when paramedics get involved with trauma, it doesn't go well. That's what the theory is. And we all know that trauma is best managed in the emergency department. So they need to go to a trauma center, the appropriate facility, as quickly as possible, which goes against the idea of calling telemetry and starting a whole cycle of having them wait behind a possible STEMI, behind a RMA, that I think that we would all advocate them just moving to the hospital and not getting involved. There's no place for IVs, we've looked at it, and, work with Jacobian, with the other trauma places in the Bronx, and we all want the same thing, get them to the hospital, whether be a pediatric patient or an adult. I think the module with periodic updates, we do it at our facilities now, and we do it at the hospitals. I think that's a perfect example. We can get together a small group to do it and look at topics that can go into that, and people can make that a mandatory part of what's training. And I think that we get more out of that than taking an ATLS course. And that course could be geared toward updates, but also the role of telemetry in trauma management.
Great. Here. Okay. Other comments on this point? Okay, so again, the motion is to replace the trauma merit badge courses with a regionally approved update
In both 4 and 5.
in both 4 and 5 for the trauma piece. Dr. Redmond.
Sorry, just before we vote on that, I mean, maybe we could put or, right? Because there may be a situation where we don't make a course and therefore wouldn't have another
I
option.
don't want to create another amendment. Glenn, would you be okay, was your amendment originally, would you be okay with just at the end of that sentence, if it said, or a regionally approved?
Yeah,
trauma
absolutely.
update? Okay.
So ATLS, ITLS, PHCLS, or regionally approved trauma course.
I'm sorry, wait, point of order, we have to vote on the latest amendment,
Yes.
and then if that's adopted or not, it becomes Glenn's amendment.
Correct.
I think if Doug agrees with
No.
that modification,
That's not the way it works.
Oh, you have to make a motion.
You gotta make a motion.
Your
Motion to
original
modify
motion
Doug.
was to strike,
ATL, any
Yes.
ATLs.
So, and so we have a motion to amend, which we have to vote on.
the motion to amend it to add the, or just Glenn's motion to amend.
If he wants to change his mind.
Yeah, I could have just changed it.
You can't just change the motion.
I make a motion to change Doug's motion to add the
It's on the
or.
table, so it has to be withdrawn or voted on.
Doug's motion, you're saying.
So I'll just withdraw.
You can't withdraw.
You can't withdraw Glenn's motion.
No.
I thought mine.
Yeah.
So we can read.
So,
We just voted yes.
okay, his motion.
Can I simplify?
Yes, please.
Glenn, are you okay with?
I just said that, he said he was.
Yes.
Okay, then if you're okay with just adding the regionally approved,
It's
you know,
technically
whatever,
not allowed.
that's fine, no issue.
Glenn, I think you should say that.
I am not opposed to it, yes.
Would you like
I
to
agree.
revise your motion?
We need to clarify.
Yes.
something.
Okay, I'm going to summarize, you tell me if I get it right. The motion that you're now saying is that you're going to, in both 4 and 5, under completion of recognized trauma courses, would be ATLS,
Three, four, and five.
ITLS,
It's 3, 4, and 5.
3, 4, and 5, PHTLS, or a regionally approved trauma update.
Yes.
Second.
That motion is seconded. Having had numerous discussions, we're going to move to vote. All in,
You write it.
Yes.
I'm changing it.
He's
I'm
typing.
changing it.
All in favor of that motion? Opposed? Are there any abstentions? Okay. At the risk, yes, sir.
The 10th edition of HLS is about to sunset and be replaced by the 11th edition. That's being rolled out next month. I would be happy to participate in
Excellent.
development of a very, very brief update program to be uploaded to the internet.
Thank you, Dr. Cooper. I'm sure CNC would appreciate it.
Thank you, Dr. Cooper.
Okay, now,
But the original
the
motion.
original document, as amended now by Glenn, right? And so by the committee, the original document as we've just amended it. Is there any further discussion on the whole document? Okay.
So this is, and we're not talking about the agency medical director.
This is not agency medical
Nope,
director.
this is totally set, please, that's a,
I'm gonna
that'll be
bring
another
strychnine.
month.
I'm going to bring strychnine.
Yeah, okay.
I made the changes.
Yes, Dr. Barber has updated all the document with the changes we made. This will be a roll call vote for the entirety of the document. Yep.
Not the medical director.
It's a, yes, well, yes, it's not a protocol. It's true, it's not a protocol, it's a policy, so we can do this by show of hands, it's a policy and not a protocol. All those in favor of the document as amended, please raise your hand. Okay. All opposed to the document? Was there one? You raised it one. Any abstentions? Okay. It passes. Thank you all. First of all, thank you for really an excellent discussion on this. And in the end, I think we settled on something that everyone is happy with, so. All right, Paul.
Thank you, Paul.
Yes.
Thank you, Paul, for your hard work.
No. Thanks, everyone.
Anything further from CNC?
Looking forward to the trauma course that everybody volunteered to write and when we can put it in play.
It's only one person.
We all voted for it.
Okay, does that conclude CNC's report?
That concludes the CNC
All right,
report.
now moving on to something less controversial, medical standards.
Oh, yes, this is gonna be very short and brief.
Microphone, please.
So, medical standards met last week virtually without traffic, and the votes were held on Zoom. There are a couple of protocols that are brought as second in motion from medical standards to REMAC for approval. And then there was another discussion on CNC, whatever they had to report, it was already addressed over here. And there was another discussion that was brought in new business, which we'll discuss later. So the first item I'll ask Dr. Lai to help with is the updated hashtag protocols. I'll be the one who's presenting this because I'm also the hashtag medical director. The hashtag battalion, specifically the hashtag EMTs and medics, it's a dedicated group of FDNY providers only who are highly trained in operations and medical care in the hazardous material environment. They undergo an extensive operational training, how to use all kinds of PPE, and also there are specific protocols to deal with different exposures. No one else in this region uses these protocols. This is specifically for FDNY hashtag, similar to the protocols of rescue medics and ESU. The 2025 protocol update does not have any changes to the medicine. There are no substantive changes. They are only changes in format, wording, and for clarity. The only changes in medical treatment are very few to bring the same treatments as those that are already present in the unified protocol. So there are no new changes. So if you would like, I will go through the track changes document quickly.
Yeah, sure. Just a quick summary of the changes.
Yes, I did send a couple of documents. One that was with track changes, one that was without track changes, and a document that just specified the changes. So we'll start from the beginning. There's a sentence that was moved from the scope section to the purpose section, but again, no change in the meaning, just for wording purposes. In the training section, it used to be a 3-week course. It is now a 4-week course. So we changed it from 120 hours to 160 hours. In the medication list, we removed ketamine simply because ketamine already appears in unified protocols as a standard of care. For the initial management of an unidentified substance, so in section 8, we had a separate protocol for hydrocarbon exposures. Since we felt that it is just appropriate to leave it to incorporate whatever was written in that protocol into section 8, so we put it there and we canceled the hydrocarbon protocol. In section 9, we updated the medication treatment, specifically the pediatric age, to reflect what is already in the New York City REMAC using unified protocols. Section 11 was updated to reflect the current New York City REMAC eye injuries protocol. That is, we added polarity, which is already present in unified protocols, with the understanding that tetracrine was already there, and we are approving this for BLS level, not only for ALS level. Section 22, we updated the name. We changed it instead of there's no abdominal pain, so we changed the name to severe nausea, severe vomiting protocol. That's the way it's written in the unified protocols. With regard to the sub-protocols, so as we said, the hydrocarbon protocol was canceled. So was the cyanide protocol, simply because it appears in the unified protocols as well. We added letters to the sub-protocols, again, just format. For the HF protocol, similarly in section 3.1, we added proparacaine. In section 6, we changed the wording just for clarity. There's nothing, it's same thing is written just in better words. hydrocarbon protocol was crossed out, cyanide protocol was also crossed out, organophosphate protocol, subprotocol. For clarity, what was written up in section 2 was moved down to below the OMA response physician because there will always need to be an OMA physician to clarify Mary approval before we actually administer this treatment. For radiation treatment subprotocol, which is the last change, pediatric age wording was changed for clarity. There might be a few more changes that might not be tracked just for wording changes, but just for clarity.
So to summarize, it's all wording changes and flow of the document. There's nothing added that's a new protocol or a new level or anything.
No, this is just to make life easier. Thank you.
All right. This comes as a seconded motion
This
for
comes as a
protocol,
seconded
so is there any discussion on this motion? Yes.
Is there, I appreciate taking out the cyanide because it's competitive. Is there differences in the organophosphate protocol from what's in the
Yes.
unified protocol?
Yes, so there are, because at the moment, the organophosphate protocol requires a class order, requires 5 patients and above. This is to allow in those unique cases where you have exposure to organophosphate for below 5 patients, allow HASTAC to take care of it.
Is that new or that was there?
That essentially was there.
Right.
Yeah,
So
there's no change.
it's not a new change. Okay.
It's not a new change,
All right.
but it's a good question.
It is, yes. Any other clarifications or comments? Okay, let's do a roll call vote to this protocol. As written.
When I call your name, please say approve, oppose, or abstain. Glenn Aceda,
Approve.
Robert Kaufman,
Approve.
Dario Gonzalez,
Got to step up.
We'll come back to it at the end of these.
Nathan Reisman,
Yes.
Pam Line,
Yes.
Nicholas Alexander,
Approve.
Doug Isaacs,
Yes.
Jeffrey Raybridge,
Yes.
Reed Caldwell,
Yes.
Louis Michael Redlener,
Approve.
Joseph Bowe, Arthur Cooper, Robert Winchell, Ed Jarvis, Mark Cantor,
Yes.
Robert Ruby,
Approve.
Christine Chen, Laura Eckley, Matthew Fink, Wallace Carter, Kevin Majel, Cindy Basilios, Matthew Harris, Jessica Van Voorhees, Benjamin Zabar,
Approve.
Paul Barber,
Approve.
David Benelli,
In favor.
Harry Coopinger,
Okay, the motion carries, and because there's no substantive change in this protocol, it's just wording and grammar, this does not need to go up CMAC REMSCO for approval. There's no protocol change.
Thank you. So
Yep.
we're gonna treat this as approved. This does not need to go.
It
to
is
CMAC.
approved, and I do not believe it needs CMAC approval because there's no change in any of the medicine. Wording.
Very good.
Next.
So this, I will send you Michelle, I will send you the final version without a watermark, which will probably go into effect in the beginning of February, but not yet. The next protocol that's called in second in motion, and I'm gonna ask Dr. Kaufman to present it, is change to the GOP, treat and place section. Brad, if you would like to discuss this, it's called a second in motion to,
So this is a motion to amend the section of the GOP on alternative transport and alternative transport destination decisions. The reasoning behind it is that the New York State 2 months ago or so passed a law that reclarifies what they call treat in place, which allows for ambulance agencies to bill for patients who are not transported to the emergency department by the ambulance. this section of the GOP was originally written and defined treat in place as requiring contact with telehealth. So changes were made to put it in line with what the state law allowed. And you can see the changes in the track changes document. Initially, it's just really some grammatical clarification in the first paragraph. If we go to the treat in place section, the words with patient release were removed throughout the protocol, so in the title as well as in section 1.1. And then in section 1.4, these were just, again, grammatical changes that you're seeing in blue. And the substantive change is this new section 1.6, which says, if a patient refuses transport after EMS assessment and treatment, the patient shall be considered as treat in place in accordance with New York State law. All required RMA procedures must be followed. An example, online medical control authorization of RMA if indicated. And the what was section 2, which talked about behavioral health complaints, was stricken as this talked about being not appropriate for telehealth, and it felt that in the future they may be appropriate for telehealth. If you go down to the alternate transport destination section, as you'll see up on the screen, these are really just grammatical changes to this section. And finally, in the flow chart, thanks to Dr. Lai, the flow chart was updated to reflect this new section 1.6.
All right, Dr. Redline.
Just a question about 1.6 and just a clarification. It doesn't read exactly like I would expect it to. It says treat in place. So if a patient refuses transport after EMS assessment and treatment, the patient shall be considered as treat in place in accordance with New York State law. What is that? Am I missing something? But is that like for any patient, or that patient who is already falls into the treatment in place category? How does that? Why? I guess I'm just questioning the word.
Yes, sir. I'm actually trying to pull up the state law that is defined.
While you're doing that,
Yeah.
Nathan's right.
Yeah, I think it's just a definition, because the law allows us to bill for treating someone in place. So previously, if we responded somewhere and gave someone all kinds of meds for asthma and gave them steroids and gave them MAG, and then they RMA, we wouldn't be able to bill. But if we define that as treat in place, then we can bill for that.
Right, I think, correct me if I'm wrong, but I think the question is if they otherwise potentially might not have fallen into that treat in place category, but now they want RMA. Are we saying that all patients, regardless of whether they initially met this category?
No, it says after EMS assessment and treatment, so that means you treated the
Right, so I
patient.
think the question was,
It's just the language is.
right, I think he's
understand what
asking
you're
for
trying
more
to get.
clarity that this means they have to, right? Is that what you're saying? It should be clear that they already are in that category?
No, I think the way it is currently, the way this is written, any patient who is treated by EMS
Right, that's
will now be considered treat in place
and that's what
after
I'm
their
asking.
assessment.
Yeah, I think that's what Dr. Redliner's asking.
I believe that's what it says now.
Because it reads as any patient.
I agree with the sentiment. I'm just not sure that it clearly, that's what it clearly says. If a patient, so any patient who's treated by EMS on scene is potentially a treatment in place patient.
Yes, I believe that's how it reads, correct.
So yeah, I think you bring up a really good point. So this is, I don't want to minimize the change. Before we had treat in place criteria that were for very low risk patients. And this changes that substantially, as the New York State law did. So herefore, where you may have, like Dr. Zabar said, a critical asthmatic patient who is treated, or possibly even a patient that was in cardiac arrest who is treated and resuscitation attempted, would qualify as treat in place under the New York State law. And,
Which essentially is for billing purposes, that law. The law was written to allow billing of Medicaid patients, et cetera.
yeah,
But you also have the second sentence here, which says that you still have to follow the the RMA protocols and online medical control, as appropriate.
so, and I'm not gonna read the whole law, but I could, certainly send it around. This was, recently approved, but in section 367Y, subsection D, it defines, quotes, treat in place, says means the administration of emergency medical services as defined by section 3001 of the Public Health Law, which is the law that governs EMS, by an employee or volunteer of an ambulance service. Such services shall be consistent with protocols promulgated pursuant to Article 30 of the Public Health Law. Right. So that's how the legislation is defining treat in place.
Yeah, so basically the law says any EMS patient can be a treatment patient.
That's, all I'm saying is that, it's like, it should start with any patient treated by EMS is considered to be treated in place. If they meet criteria for RMA, then, I just think this is a little confusing and it sort of happens
You're
afterwards.
saying it can be written with a little more clarity.
That's
for
right,
the
that's right.
provider.
I agree with the sentiment and I agree that this is an important piece of it, so.
Question, on these treatment place patients, they still got to call under control for RMA, or how's that work?
It would follow whatever the current RMA program, so if you would have to call for the RMA, whether they were treating place or not, nothing's changing there, you still gotta follow that process.
Then aren't we documenting them with RMA? Are they going to bill them? I think it's the billing, I don't understand.
You're saying, so
Treatment place
are they
with
gonna
RMA,
sign
I
the,
don't-
are they sign the
they can't
RMA and the
vote,
PCR
yeah.
basically? Right?
So they get someone to call on under control even though they're treating in place, basically, and if they're not transporting, they got to go under control?
It's really, it's really a refusal of transport now, right? Because they got treated in place, a refusal of transport, right? That, or further care.
So I think what you're saying is an agency, it's up to the agency, could bill a patient who's been treated by EMS providers and refuse transport.
But it's like the billing, does the crew have to call on under control to RMA them, even though it's under the treatment place guidelines?
The decision to call, I think, online medical control
That's
is
an
in
operational,
accordance with the policy. So, for instance, for the fire department, a crew has to call, let's say if they have a high index of suspicion, or they provide treatment, so they would still have to follow those same guidelines. This won't change
So the operational 911, so that's an operational process, that will not change, correct?
Not according to.
Not according to this, Glenn, yeah, go ahead.
I'm sorry, the only thing that may be problematic is an RMA who refused all, where a third party called for them, and I think we need to somehow document that so we don't confuse crews on how to handle those. Those would not go to billing, none.
Right, so that's like a separate patient, it's like, are they a patient or not? What defines someone else called for them, right? That's outside of this document, yes, a point that should be clarified.
I mean, I would almost say it's like two separate, oh, sorry, Glenn, go ahead.
Yes, go.
No, it's interesting because when we initially passed this, it was the federal ET3 program.
Yes.
And so their treatment place required that telehealth piece.
Yep.
The way the governor now has passed this new thing is that Medicaid will pay for it, right? These situations are much broader. It doesn't say it has to be telehealth.
Correct.
And so, I mean, when you look at it, yeah, it is going to allow you to bill, anybody to bill for RMAs, but quite honestly, throughout the country, there are plenty of systems that bill for RMAs,
Yes.
right? And
Because they're not refusing all care, they're just refusing, I don't want to go
the
to the hospital.
transport, right. So I think this is just written to be more in line with what, Hochul had passed for the Medicaid aspect. Now, for us, our legal is saying, well, you can't just bill Medicaid people, it's got to be everybody, because otherwise.
Correct. It's
there's
gotta
a
be fair,
discrep-
yep.
right. So we wanted to at least get that language in place, and so I think that's what was meant.
Yeah, and I think everyone's in agreement with Cons. I think Michael's point only is that, could it be, if we're having this discussion, could there be some more clarity in how we write it for our field provider?
And, billing is not really our issue.
No, no,
We're
right.
patient care. I mean, what the billers do, they'll argue with us saying, no, we got to it. I don't know if they have to do it. They don't.
Yeah.
I would just make the point that,
Documentation will be the issue. To
Doc-
ensure they
ab-
capture all
well,
the documentation.
documentation is part of,
to requirements.
absolutely is part of medicine as well, but as far as the billing piece, right, when they come to us and they ask for certain things, I have nothing to do with the billing. I could care less. I mean, yeah, we want to get money.
Fred was next, and then.
no, I was just gonna make the point that I don't think this is something that a field provider would decide. This is, it will be an agency decision about when to send a bill.
Right, and then, Michael first. and then-
I would say, I would just say, in order to maintain that language, right, so any patient treated by EMS is considered a treatment in place, right? And I would just say, then continue on with the second, follow all rules for refusal of transport should be followed, regional rules for, for refusal of transport should be followed. I mean, again, it doesn't matter, I guess it doesn't matter, does this language matter to the field providers?
Yeah. I think it's a little of splitting hairs at this point, but, go ahead.
One of the sticky issues is, part of RMA is determining the capacity of the patient to
Mike, use
refuse.
Mike.
Okay, so if telehealth says that they could stay there, and they're sick, and they call us, and they say, this patient.
Use the
Use the microphone.
And you go to the doctors, not the EMS.
Use a microphone.
Oh. This is just for taping, or?
Yeah.
Just for taping?
Yeah.
It's not for expanding to talk?
We can hear you, yeah.
Oh, you can hear me anyway.
There you go.
Testing.
Yep, go ahead.
So part of it is RMA's capacity. So that as far as the medics are concerned, yeah, they know where they are, who they are, date and time. A lot more capacity is to understand the disease process, to understand how it's affecting them, to understand the risks, to understand the benefits, what are the alternatives. Now, if we disagree with the telehealth person, then we're going to have to say we're turning down the RMA. That gets sticky about them calling us for all treatment releases because we may not think the patient has capacity to refuse.
Right, but this doesn't change anything with the existing protocols in the region regarding telehealth, RMA, or any of that. All this says is that a patient who previously might have been an RMA and considered just an RMA are actually, under the definition of this law, treat-in-place patients. But those processes, those operational processes, and those protocols regarding when you have to call for RMA and things like, none of that has changed.
Well, I still don't know then what to do. Because like that situation comes and I think the patient needs to be transported and the telehealth doctor doesn't think he needs to be transported.
Well, medical control.
And the EMS is still looking at which way, then it's sticky. I just want to know
I
what that.
would just say that the EMS provider follows online medical control, not the telehealth.
Right.
I think the online medical control, we've made clear on this committee, is the authority as far as EMS providers are concerned.
And if there's ever a question like that on call where there's a disagreement, online medical control is the arbitrator of that, right? That's who's ultimately responsible, the online.
I guess what I'm thinking is, so that we're going to be reassessing the telehealth assessment. Well, the telehealth that knows them, the patient of theirs for years, we have to reassess their judgment and say, we're not going to agree with them in a snapshot of time. We may say, this patient has capacity to have to go. And they say, wait a second, we've been treating this patient for 10 years. So, see what I'm saying? So,
Yeah, I do see what you're saying, but
calling
don't-
for RMAs for treatment in place.
But usually what happens is if it's not a.
Microphone.
And
Sorry. Oh, you got it. It's on.
Fantastic, thank you. No, but if it goes to tell a patient, they may deem the way it's gonna be pushed back to element control, if they deem it's not appropriate telehealth. It's not like gonna be a line between telehealth and element control. It's been pushed to element control, and then we have oversight over, that has, oversight over this whole process, but it's not, you're not like on a party line with telehealth doctor and yourself. Once they deem it's not health, patients push on medical control, and then that decision happens at that end. So it won't be contradictory, it's just pushed now to on medical control.
I understand what you're saying, but I'm still not sure of the answer, because again, if the telehealth doctor says keep them in place, and they call me,
But at that
and I
point,
assess it, says this guy can't stay there.
Yes.
So
The
now-
answer is that the
so
online
then
medical
what
control
happens-
physician
what
is the
happens
final
then?
authority.
You see what I'm saying?
Yeah, I'd just like to remind everyone that the garage does close at 7, so.
Motion to call the question.
What are we voting?
We're voting on the change in this,
Well, now we gotta vote to call the question.
well, right, first, but then.
We don't actually.
Okay, he doesn't actually vote. Moving along, if there's no other discussion, we can vote on the changes to this section of the GOP. Because it's part of the protocol, well, even though it's GOP, it still has to be roll call.
So you're saying if I wanted to make a motion to change the language, I should do it now?
If you do, you should, otherwise, are you doing that? Do you have better language, or? Okay, thank you. Roll call vote, please.
When I call your name, please say in favor, oppose, or abstain. Guanaceta?
Yes.
Bradley Kaufman? Dario Gonzalez?
Yes.
Nathan Reisman?
Yes.
Ben Lolai?
Yes.
Nicholas Alexander?
Yes.
Doug Isaacs?
Yes.
Jeffrey Raybridge?
Yes.
Reed Caldwell?
Yes.
Louis Marshall? Michael Redlener?
Yes.
Joseph Schenker? Joseph Bo?
I can talk.
Yes.
Yes.
Arthur Cooper?
Yes.
Robert Winchell? Ed Jarvis? Mark Cantor?
Yes.
Robert Ruby?
Yes.
Christine Chen? Laura Agapoli? Yes. Matthew Pinker, Wallace Carter? Kevin Manjel? Cindy Basilios? Yes. Matthew Harris? Jessica Van Voorhees? Benjamin Zabar?
Yes.
Paul Barber?
Yes.
David Benelli? Eric Linder? Motion carries.
Motion carries. Next item of business.
Okay, the next protocol that's brought is second in motion to REMAC for approval. I'm sorry, my time is up.
Yes, speak faster, say louder.
Sorry, just rolling it. Is the AMS protocol and specifically a change to the CFR section. I'm going to allow Dr. Zeba to explain the rationale behind that.
Yeah, so basically the history is in the 2019 protocols when they were still separate, CFR, at that time it basically was saying anyone with altered mental status, give them a glucose solution. Then when we went to the combined protocols, we had, because EMTs had glucometry, they said check the glucose for an EMT and then give them glucose if it was low. We don't believe that the intent at that time was to say, oh, a CFR who a patient, as a training issue says, I'm diabetic, I think my sugar's low, can I drink the soda? I don't think the intent was to prevent CFR from allowing that person or assisting them in drinking a glucose solution like a soda. So the suggestion is to basically put the language back in that for CFR only, they're not checking blood glucose. It would say, it says, if the glucose is suspected to be low and they're conscious and able to drink without assistance, give them a glucose solution or other sugar-contained beverage, and the rest of it is unchanged.
Okay. Discussion on the motion.
Can I speak on it?
I just want, any committee members have a discussion on the motion first? Okay, please use the microphone. If you could just start by saying your name.
Good afternoon. My name is Michael Schreiber. I'm the Health and Safety Officer for the Uniform Firefighters Association. It sounds like this, changing this language is housekeeping, right, for the protocol, but I would argue that it has actual real-world ramifications for my members. Administering glucose will increase response times for fire-related emergencies. We have engine companies doing 7,000 runs. That's a run almost every hour of every day. On top of these runs, members have to train, do building inspection, maintain rigs and firehouses in good operational order. At what point does somebody from this body, the department, the city, take responsibility for the damage they are doing to the members you claim to support? My members suffer mentally and physically from the workload dumped on them from people who say, you can handle it. Extended on-scene time. Adding glucose to the CFR protocol will increase the amount of time firefighters spend on-scene, making them unavailable for fire incidents that require firefighter response. Fires, explosions, collapses, train emergencies, motor vehicle accidents, gas leaks. These are the core responsibilities of FDNY firefighters. Adding medical duties will stretch resources thin, reducing the number of engines available for fires. Fires do not go out without engines. Period. This is a duplication of service. If the concern is lack of medical personnel, get more EMTs, put more ambulances on the street, and stop trying to do more with less. This mentality is damaging and not the solution. Thank you.
Okay, thank you. Other comments, other discussion?
I would just say that I, fully appreciate all the comments we just heard, but just want to be clear that these protocols do not apply to firefighters. These are CFR protocols that when we have a certified first responder who's caring for a patient, it allows them to treat them appropriately. These are medical protocols.
So for clarification, how does that not affect FDNY firefighters who are CFR?
Well, I think what you're referring to is an operational issue within the fire department, and whereas this protocol is a regional protocol that is applicable to all CFRs in the region. As to what level of provider goes to what type of call within a certain agency is not the decision of this committee.
Right. No, I understand that the department would ultimately make that determination. But, making those decisions that you make here have ramifications, which I indicated for my members. So it's not just a housekeeping, exercise. It has real components to my members. And just adding another level of, response is at some point, it's too much.
Yes.
Just for clarification, within New York State, the only CFRs that exist are FDNY firefighters.
No,
So
I
it is
understand that, but
specific to our
yes,
firefighters.
the protocol is a regional, and in the case of New York State, the statewide unified protocols, but they're not agency specific. Now, at a certain level, if only one agency has them, that may be the case, but they're not, in other words, the protocol's not written.
I understand. It's not written specifically for the FDNY, but it only applies to the FDNY.
I understand. Dr. Barber.
So we often have protocol changes that are because medicine changes or there's a regional update or a national update. Can the protocol committee or any representative discuss the reason for this protocol change? There had to be some impetus. Dr. Zabar?
I think Dr. Zabar did.
Dr. Kaufman can correct me, but I believe that this was a question that came forward from the EMS Training Academy that oversees the training of CFR, and I believe it was something to the effect of, in the past, CFR, if they had a patient who's diabetic, could give them some soda, are they no longer able to do that? And it seems like in the current protocol, they're probably not really supposed to do that, and when we saw the history of it, that was sort of the impetus, I believe, was a question coming from training, right, Brad?
Dr. Benelli.
So there is a CFR section in the altered mental status protocol. There's always been a CFR section in the altered mental status protocol. Who is dispatched and who responds to a specific call type is up to the fire department and in the 911 system. We are here to write the protocols and what we expect from CFR. I don't think that they are going to be on scene if they respond anyway. I think that, trying to address hypoglycemia by a simple measure of giving someone a glass of orange juice is not something that provides excessive burden on anyone. Thank you.
Yes.
I know we're here to do medical stuff, but you can't ignore the operational stuff. Something going to pass affects operations.
Tony, can you speak up a bit? Yeah, people are having a hard time hearing.
If something we pass here, we know darn well it's going to affect operations, we have to consider it. We can't just say we're a medical committee and, it doesn't affect operations. If it affects operations, we have to take sensitivity to that.
Yep.
It's like the providers in the field. We pass something to the providers in the field and the medics say, they tell us something. You can't just blow it up, tell we're the medical committee, you got to do it. You have to hear from the field.
We are hearing. I don't think anyone's blowing it off.
I'm talking about, again, so I'm emphasizing the fact that when we vote, we should consider that. Instead of that's a big deal to make an engine company. It's not a small deal.
You can consider
It's
that.
not a small deal taking blood and getting sugar. It's not a small deal. We think, it's easy. It's not. People they're being held at the scene extra than they have to be. So we got to consider the weight of holding an engine company at the scene. For this, give them oral something, we get there and give them IV. That's really the weight. You got to decide. That's not just all passing a medical protocol. You have to decide that decision. That's what I have to say.
Okay. Yeah, go ahead.
So the concern was not assisting somebody with orange juice. That is absolutely not a burden. If we're there, that's absolutely something that can be done. The concern is being equipped with the glucose and then being sent out on additional runs that we currently are not being assigned to. We are not assigned to AMS. I have the 26 call types that we are assigned to.
Yep, so I understand that, and I think that's why, the point I was trying to make is that whether you get assigned that call type or not, it's not up to the, I mean, I think you know that, it's not up, right? It's a department decision, ultimately. Dr. Redlener.
Thanks for coming, by the way. So I'm Michael Redlener from Mount Sinai, but I think that, right, in my view, this change enables people to take care of patients on scene. It doesn't change, right? Like, again, I would just support what Dr. Raybridge is saying, which is it doesn't change the dynamics or the response obligations or that, but I do think that making sure that this is the protocol helps responders on the scene should they encounter something like this. And so I would, I would support this change, but I am sensitive to the operational implications.
There's a nuance that's being missed here. So if you were to equip engines with the glucose, they could then open the door to being assigned to AMS case call types. We currently don't have that and are not assigned to them. What was said before by the doctor, assisting people with their own medication, in this case, orange juice, we can absolutely do that. Would the department assign us to AMS if we got the glucose?
I'm not sure that anything in here mandates you to get the glucose. It just says administer a glucose
It opens the door,
solution
right?
or other, huh?
It opens the door.
I'm not gonna argue that. It enables, the protocol enables, doesn't mandate. The mandate may come from somewhere else.
Exactly.
Yeah. We're gonna lose our quorum to the garage, but, so I appreciate
I
the
have
comments.
I have like 7 minutes before the garage closes. I have to leave.
Joe is going to find out if the garage is open
Okay.
at 7 or 8.
Okay.
Said seven.
I was told
They said
seven.
seven.
Okay.
Seven.
Can we, anyone have a problem with moving to vote on this protocol now? Okay. Roll call vote since it's a protocol. Alphabetical.
When I call your name, say approve, oppose, or abstain, Juanaceda.
Abstain.
Bradley Kaufman.
Approve.
Jerry Gonzalez.
Approve.
Nathan Reisman.
Approve.
Alan Lalai. Nicholas Alexander.
Approve.
Doug Isaacs. Jeffrey Raybridge.
Approve.
Reed Caldwell.
Approve.
Louis Marshall. Michael Redlener. Joseph Shanker. Joseph O.
Yep.
Cooper. Robert Winchell, Ed Jarvis, Nicholas Perry, Mark Cantor.
Approve.
Robert Groupie.
Approve.
Christine Chen.
I heard abstain.
Laura Abdul. Matthew Fink, Wallace Carter, Kevin Magello, Cindy Basilios. Matthew Harris. Jessica Van Voorhees, Benjamin Zabar.
Favor.
Paul Barber.
In favor.
David Benelli.
In favor.
Eric Linder.
Motion carries, and due to the loss of our quorum, we're going to have to adjourn the meeting at this time, and
There was another new, there's a new.
we don't have a
item
quorum
business.
now, so I mean, if you want to bring something up, you can, we just can't vote on it, everyone's running to the garage.
Okay. At some point, Dr. Shire should bring up your.
It was tabled, so why don't we bring it back?
We don't yet.
Okay, thank you.
It's up to you.
Okay, so why don't we get the minutes now? Nothing else.
Just say, we'll just say that we adjourned